AETCM, the emergency medicine channel. Today, a 50-year-old male with no comorbs presented to ER with history of chest pain with palpitation, which started 10 minutes back. Initial 10-second assessment, airway was patent, able to talk in one full sentence, no stridor, gargling, hoarseness of voice, grunting, no pooling of secretion. Breathing, respiratory rate of 20 per minute, saturation of 97%, bilateral air entry present on auscultation, no use of accessory muscles. Circulation, heart rate was 180 per minute, BP of 120 per 80, all peripheral pulses palpable, no two large bore cannulas inserted at this time. Then disability GCS 15 by 15 and pupils equal and reactive to light, exposure temperature of 99.9 degree Fahrenheit. Adjoint to primary survey, we took an ECG which shows a narrow complex regular tachycardia with absent P waves. Okay. At this point, patient was connected to cardiac monitor, which also showed narrow complex regular tachycardia. Trope point of care was
okay. So we have a patient with who presented with chest pain and palpitations, right?
Yes,
chest pain and palpitations. So only abnormality which you found in the primary survey was tachycardia. Anything else was there?
No, ma'am.
With the history of chest pain and palpitation. Okay. So heart rate is 150. So what we will do first? We will have to reassess the primary survey at this point of time. So here the abnormality is tachyarrhythmia because heart rate is more than 150. So what all things will you reassess?
Reassess we have to see the patient's airway is patent or not. If the patient's saturation is normal, or the patient, we have to assess whether the patient is hemodynamically stable or unstable. Since the patients are
so airway you have checked, airway is patent. Then breathing. What all will you check?
Any tachypnea, saturation drop, then
respiration, saturation and any basal crabs should be checked. That is to check for any features of cardiac failure. Okay. Then circulation.
Circulation, BP, heart rate. Any peripheral pulse, whether patient is in shock.
Okay, peripheral pulses. Then you will have to, already you have told that, attach the cardiac monitors, then put an IV cannula and also take a 12 lead ECG. IV cannula and ECG. And disability?
GCS we have to assess whether there is any decreased level of consciousness. Altered sensory.
Okay. So that is to check for any features of instabilities there. So what all are the things?
Basically, for instability, we look for hypotension, altered mental status, any signs of shock or ischemic chest discomfort or signs of acute heart failure.
Okay. So was that patient, so the patient didn't have hypotension, sensorium was full, signs of shock. So the patient had history of chest pain, right? So was he having pain at that time?
Yes, ma'am. Active pain was there at that time.
Okay.
So
any features of heart failure? Nothing?
No basal crabs. The patient was not on hypotension. The GCS was 15 by 15 with conscious oriented patient.
So if active chest pain is there, then you will have to go for synchronized cardio. So what was the ECG this patient's?
ECG of the patient shows narrow complex regular tachycardia with absent P waves.
Okay.
So most likely supraventricular tachycardia.
Okay. And unstable. So we'll have to go for synchronized cardiac conversion. If patient didn't have any acute chest history of chest pain with palpitation was there, is there, then we'll have to go for synchronized cardioversion. If patient is only having palpitation right now, then we can go for medical management. So what was done for the patient?
Since the patient was hemodynamically stable, we given a dose of injection adenosine.
Okay, so at the moment if the patient is telling no pain, then you can plan on giving adenosine. So before going to adenosine, can you explain this chart?
If the patient is hemodynamically stable, we will say there's the signs of a compromise, like hemodynamic compromise is not there. It's a white complex QRS of more than 0.12. If it is not a white complex, narrow complex, we go for vagal stimulation or adenosine, beta blockers or calcium channel blockers. We'll see whether this SVT is revertible or not. If it is white complex and non-revertible, we'll consider adenosine, then anti-arrhythmic infusion and expert consultation.
Okay, so since if the patient is having active chest pain right now, we'll have to plan on synchronized cardioversion. So for doing synchronized cardioversion, you will have to sedate the patient. Then what all will you do?
Sedate, cardiac leads should be attached.
We have to take the consent from the bystander, or if the patient is conscious, then attach the cardiac leads. Then
monitor the wave and give a DC, synchronized cardioversion.
How will you give synchronized cardioversion?
We have to set the mode in defib to say
synchronized mode,
and will give maximum joules starting from 50 joules.
Okay. So usually previously it was told that if the patient is having regular tachycardia, narrow complex, then like SVT and all, we start with 50 joules. If it is regular but wide, we can give 100 joules. We can start with 100 joules. If it is irregular, narrow like AF and all, we will have to start with 150 joules. That was in previous ACLS guidelines. Now it is told that maximum joules can be given. So we can start with 50 joules and we will have to press the sync button and we will have to shock the patient and we will have to keep for 10 seconds. That is if the patient is unstable. So if the patient is stable, then we will have to go for, we will have to decide whether it is wide or narrow. If the patient is having a wide complex, we will consider adenosine only if it is an SVT with aberrancy. What is SVT with aberrancy? SVT with any bundle branch block. That means it will be wide QRS complex will be there with the T wave. P wave won't be there. So if it is SVT with aberrancy only, we will be considering adenosine. So but our patient is stable. No chest pain right now, stable, SVT, narrow. Okay, so first we will have to do vagal maneuvers. So what was done for the patient?
We given a vagal maneuver, vagal carotid massage, but patients.
So how will you do carotid massage?
We have to on the
before doing carotid massage, should we rule out something? Carotid bruit. So you need to auscultate on the carotid region. So where should you auscultate? Where is the carotid site?
C6, at the level of C6 spine.
At the level of thyroid cartilage, just in front of, just below the angle of mandible. So there you will have to auscultate and see for any carotid bruit, whether it is there or not. If that is not there, then you can do vagal massage. So how will you do? How much time will you massage?
We have to massage at least minimum of 2 minutes.
No need of 2 minutes. And will you massage two sides together?
No, only one side.
Only one side. That too less than 20 seconds. Minimum of 5 to 6 seconds, maximum 20 seconds we will have to massage and see. Okay, so if that the carotid massage is not working, what are the other steps we can do?
Other vagal maneuver we can give is like Valsalva we can try, ice water on face.
Ice water on face is usually done in children. That is called as diving reflex. We can directly we won't be applying ice or ice water on the face. We won't be doing that. We will cover the ice or ice water with gauze and we will be applying on the forehead on the ice. That is done in children. Okay. Other Valsalva's maneuver?
Gagging. Then this plastic bag.
What we can do is that we can ask the patient, if we have a syringe, 10 cc syringe, we can remove the needle and ask the patient to push, blow through it and push the plunger out. That can be done. or what we can do is, if the patient is at home and all, if we are not in a hospital setup, and if we are sure this patient is having a past history of SVT, if the patient is having history again and we are not in a situation to check the carotid bruit or do the carotid massage, what can be done is we can ask the patient to close the mouth and nose and expire against the closed glottis. That can be done. Or other method is one modified Valsalva's maneuver is there. How is it? Just make the patient in semi-recumbent position, ask the patient to blow through the 10 cc syringe, then immediately after that make the patient in supine position with leg up, then again make the patient in semi-recumbent position. That is modified Valsalva's technique. These all, why we are doing all these things?
To stimulate vagus nerve.
To stimulate the vagus nerve so that the heart rate will come down. Okay. So for this patient, what was done?
We started with we tried a vagal maneuver. There was no revision was there. So we next we given injection adenosine 6 milligram IV start with, followed by 10 ml NS bolus.
Okay. So what is adenosine?
For antiarrhythmic.
Antiarrhythmic. It is a class 5 antiarrhythmic drug. So why we are giving adenosine in this case?
Adenosine directly like stimulate
AV node. So adenosine is having an action in the heart and also peripheral endothelium. So in the heart, what will do it will produce a transient heart block like thing, especially in the AV block region. So adenosine will reduce the heart rate. So that's why we are giving, and also in the peripheral vessels it will cause vasodilatation also. So how will you give that? So if you are planning to give adenosine, where should you put the cannula?
As close as heart. So
as close to the heart. Okay.
Either an EJV or any peripheral. As close as heart, the adenosine's action is less than 6 seconds. So it have to reach the heart within 6 seconds. So as close to.
So 6 mg we will be giving, followed by immediate flush. NS flush should be given, and we need to lift the limb so that it will reach the heart as fast as possible. Okay, so that is through a peripheral IV cannula. If we have a central line, what will you put? How much dose will you give?
Less. Like
only half dose requires to be given. Okay.
3
So what is the dose of adenosine in children?
Children is also 0.1 milligram per kg.
So that is a dose in children, 0.1 mg per kg. Okay, so if that is, so how much time will you wait for the adenosine to act?
Within seconds.
Within a few seconds maximum, or within 1 to 2 minutes the response will come. So before giving adenosine, what should you tell the patient?
That there is a chance of giddiness patient can feel. So then chest discomfort can occur.
Chest discomfort can be there, giddiness can be, sweating, hypotension can be there. Sometimes there is a risk of cardiac arrest, especially if the patient is having any underlying heart block and all. We are producing a heart block like this, so they are having a risk of cardiac arrest. That you need not tell the patient, but we need to anticipate all this, and we'll have to arrange the crash cart ready. Okay. So that should be kept in mind. And any contraindication for giving adenosine? Heart blocks and patient with severe bronchospasm. Okay. So how much time will you wait? 2 minutes. After that, if the patient is not reverting, then
we will give double the dose, 12 milligram. And if it's a central line, 6 milligram.
Okay, double the dose. Okay.
And we'll still wait and see whether the revision is there. If it is kind of like resistant, then we'll again give a 12 milligram, and still resistant there, we will go for DC sync.
Okay, so according to our algorithm, we will give 6 milligram and 12 milligram only. According to UK guidelines, they suggest to give one more 12 milligram. Okay, so that is the maximum dose we will give. And what will we do if the patient is still in SVT even after giving 12 milligram of adenosine?
Cardioversion, like according to ACL is expert consultation.
Expert consultation is required. Then any other drugs we can consider.
Amiodarone, anti-arrhythmic drugs we can.
Yeah. Okay. Amiodarone is one choice. Then here we
calcium
have
channel blockers.
calcium channel blocker and beta blockers. So what calcium channel blocker can you give?
Diltiazem or verapamil.
How much will you give? So we can give diltiazem or verapamil. So diltiazem, if you are giving, you can give 0.025 mg per kg, and we can wait for like 15 to 30 minutes, and if still the patient is in SVT, this we need to wait for some more time, like a minimum 15 minutes. Then you can give, still if patient is in SVT, you can give 0.35 mg per kg to a maximum of 360 can be given. Okay. And verapamil, if you are giving 5 to 10 mg milligram should be given, and you can repeat accordingly. Okay. Or if you are giving a beta blocker like metoprolol, how much you will give?
25.
Tablet, if you are giving 100 milligram you can give, but injection if you are giving 5 mg, because there is a chance of hypertension. So check the blood pressure again and then give 5 milligram. Okay. So what happened to this patient?
Patient after the first dose of 6 milligram, patient reverted and reverted to normal sinus tachycardia. Then vitals at that point is a pulse rate of 110 per minute, saturation of 98, and BP of 170. Since patient is also was febrile, we also given injection PCM 1 gram IV stat along with panandemicit. Then
okay, so did you repeat an ECG after that?
Yes, ma'am. Repeat ECG also showed sinus tachycardia.
Why we are repeating ECG?
To show the most common cause of SVT can ischemia. We have to rule out what's the cause of SVT. One of the causes is ischemia. Repeat ECG doesn't show any T inversions or ST elevations.
Okay. Not only ischemia, any chances of any conduction problem, like any aberrant pathways like WPW syndrome and all, we will be seeing in ECG. So what all are the other causes of SVTs? You told ischemia. Any other cause?
Heart blocks are
not blocks, aberrant
pathways.
Okay.
Re-entry, different causes. Pathophysiologically, either re-entry or enhancement or any autorhythmicity.
Okay. So when all can you see SVT? Why we are taking repeat ECGs to know what led to the SVT of this patient. So usually we have two types. SVT can happen in a AV nodal reentrant tachycardia or an atrioventricular tachycardia. So what is this? You have heard about AVNRT, AVRT?
Yes, ma'am. AVNRT, AV nodal reentry.
This is AV nodal reentrant tachycardia. This is
AVRT is a node any atrial tissue alone.
Okay. So AVNRT means the node is having some problem. So just imagine this is the patient's AV node. What can happen here?
AV node above ventricle, abnormal re-entry or any activation.
Okay, so what is happening is we have the heart here, SA node is producing an impulse, and this impulse will come to the AV node. So AV node we have two pathways. One is a slow pathway like this, and one will be a fast pathway. So usually the conduction will slow pathway is slow, but it is having a lower refractory period, but fast pathway is fast, but it is having a prolonged refractory period. So suppose electrical activity is coming through the fast pathway and conducted, and usually what will happen is there will be a re-entrance from the slow pathway to the fast pathway. So this will cause a re-entry phenomenon, and that will cause SVT for the patient. That is why it is called a supraventricular tachycardia, and it is happening above the heart. above the ventricles. That's why when the bundle of is getting activated, what will happen? It will be narrow complex. That is one way. This is called as this is what is called as a typical AV NRT. That means from slow it is going to the fast. So what will happen when you look at the ECG? We will be seeing a narrow QRS with a T wave. Okay. And where will you see the P wave?
P wave with QRS.
Either you will see either you won't see a P wave or it will be inside
QRS.
Okay. Inside the QRS. Okay. That is typical. Sometimes you will see a T wave which is, so this is the QRS complex, and we will see a T wave which a P wave which is far from the QRS. This is called as an atypical AVNRT. That is usually happening when the fast pathway is activated and the re-entrance happen in the opposite direction. So if it is happening in usually slow to fast, if the re-entrance is happening, that is typical. There you will be usually seeing a narrow QRS complex with or without a embedded P wave and a T. And if the P wave is far away from the QRS, then that will be usually atypical, or it will be from fast to slow. That is in case of a AVNRT. Okay. Then what is AVRT?
AVRT is triggered by premature atrial or a premature ventricular uptake. It's also a re-entry kind of circuit,
but outside
the AV node.
Okay. So what will happen there? This is our heart. Usually SA node will stimulate the AV node. So there are that is a normal conduction. If there is any aberrant pathway which is going on, like a bundle of Kent and all, so either there will be an aberrant pathway which is going through the left side, or it can go through the right side. Okay. So if it is going through the left side, what will happen? This will enter the AV node, and there will be a re-entrance phenomenon. So either just imagine here the aberrant pathway is like this. What will happen? Some conduction will go like this, and it will enter through the AV node, and it will go around like this. So this is called as, any idea? Orthodromic. That means it is entering from the aberrant pathway to the AV node, and from the AV node it is going to the bundle of His. So it is going like this. It is called as orthodromic, and since it is going through the bundle of His, this also will be having a narrow QRS. So we will be seeing a narrow QRS with the T wave. Whereas if it is going in opposite direction, what will happen? If it is going through the if it is going in the opposite direction like this, then it will be having a wide QRS will be seen with the T wave, P wave. Without this thing, we will be seeing a wide QRS complex. That is called as antidromic. So SVT can happen because of either an AV NRT or an AV RT. So usually this aberrant pathway, one of the examples of aberrant pathways,
bundle of Kent.
Bundle of Kent will be there, and especially in WPW syndrome and all, we will be seeing this. So patients with WPW syndrome can have a risk of SVT. So we are repeating the ECG to see if the patient is having any features of WPW syndrome. So what will you see in the ECG after SVT is corrected?
In WPW?
If the patient is having WPW syndrome. Delta wave. So just imagine we have corrected the patient's SVT, we are repeating an ECG. Okay, so patient is having an aberrant pathway. So what will happen in WPW syndromes and all, there is an aberrant pathway, so the PR will be shortened. So, and the the ventricle is getting prematurely stimulated by the aberrant pathway. So what will happen? A slurred T will come, and then a QRS complex will come like this. So this is called as a delta wave. The delta wave will be seen in WPW syndrome. Okay. And that delta wave can be a positive delta wave or a negative delta wave. So WPW, two types are there, A and B are there. So A usually happens in, okay, so if it is a B, usually the delta wave will be negative. It will come like this. A negative delta wave will come if it is B, and if it is a positive delta wave like this will come. So A usually happens in right-sided aberrant pathway, B happens in left-sided aberrant pathway, like that. Okay. So what? So this patient's repeat ECG was normal only.
Normal.
Okay. Then what was done for the patient then?
For the patient, we give after adenosine reverted and ECG showed normal sinus rhythm. No further episodes were not there, and then we give an expert cardiology consultation.
So what do you think they will do then?
They must alter study.
Holter study should be done, or any electrophysiological study to look for any arrhythmias. Okay. Anything else? Okay, thank you.